My name is Heinz Kisslinger from the Medical University of Vienna, and I am presenting at the SOHO 2016 meeting about perspectives and future directions in essential thrombocythemia and polycythemia vera. It's important to have an exact diagnosis because essential thrombocythemia consists of early myelofibrosis and WHO classified essential thrombocythemia, so it's necessary to perform bone marrow biopsy in order to differentiate early prefibrotic myelofibrosis from ET, which is important for fibrosis-free survival, as we have published very recently in leukemia. Fibrosis-free survival is superior in WHO classified essential thrombocythemia in comparison to the British ET classification, and also the overall survival is superior in WHO classified essential thrombocythemia. What is about the risk factors for thrombosis in WHO classified essential thrombocythemia? The IPSET thrombosis. There are 4 factors which play a role: the age beyond 60 years, cardiovascular risk factors, previous thrombosis, and CHEK2 positivity. This slide shows the revised IPSET thrombosis score published recently. It divides the risk categories to 4 risks: very low, low risk, intermediate, and high risk. Very low risk patients with essential thrombocythemia are those with age below 60, no CHEK2 mutation, no prior thrombotic events. Low risks are those patients below 60, no prior thrombotic events, but CHEK2 positivity. Intermediate risk are those patients who are beyond 60 years, no CHEK2 mutation, no prior thrombotic event, and high-risk patients are those with thrombotic events in their history or beyond 60 years and CHEK2 positivity. How should we treat these patients? This has been published or has been shown by a very recent paper from the Spanish group showing that aspirin has some advantages in avoiding venous thrombotic events in CHEK2 positive patients, but there is no difference in CHEK2 positive patients using aspirin in those patients having arterial thrombotic events. But in the calreticulin positive patients, you don't have any beneficial effect from aspirin, but the risk for bleeding in those patients is higher. So it does not make sense to use aspirin in calreticulin positive, low-risk essential thrombocythemia patients. What is about the platelet count and the correlation with thrombosis? There is no correlation of platelet counts at the time of diagnosis, so elevated platelet counts rather protect from thrombotic events than promote the thrombotic events, according to several analyses of this issue. On the other hand, there are 2 papers now who show that at the time of thrombotic events, usually the median platelet count is higher in those patients who had thrombotic events in comparison to all the measured platelet counts during the follow-up. So the platelet counts plays a role for the appearance of thrombotic events during follow-up, which is important, and dependent from the classification how the essential thrombocythemia diagnosis was made according to the old PVSG criteria or according to the British ET criteria or according to the classic WHO essential thrombocythemia diagnosis criteria. It's dependent which compound you should use. If the patients have been diagnosed according to PVSG, it's better to use a cytoreductive therapy, for example hydroxyurea, or also interferon if possible. On the other hand, in WHO classified essential thrombocythemia, it's sufficient to use only anagrelide. This slide shows the Central European guidelines for treatment of essential thrombocythemia. And we show that beyond 600,000 platelets, it should be treated with platelet-lowering compounds. In our setting, we use in essential thrombocythemia, according to the WHO classified, always as first-line anacrylate and as second-line hydroxyurea. At platelet counts beyond 1,500, we use hydroxyurea as first line in order to prevent bleeding events because anacrylate in very high platelet counts can promote bleeding in this setting. What's about treatment of polycythemia vera? There is the possibility, besides hydroxyurea, to use interferon in these patients. Interferon has shown to cause high complete remission rates concerning hematologic response, and a partial response is achieved in almost 100% of the patients after more than 1 year interferon treatment. And we saw in our phase 1, phase 2 study that the JAK2 allelic burden goes down to almost zero in about 20% of the treated patients. The alternative is certainly in hydroxyurea resistant patients. This ruxolitinib is able to create a response rate, complete hematologic remission in about 20% of the patients, and it has a striking effect on the spleen size and also on the hematocrit level. It improves the constitutional symptoms, improves viscosity, and also improves sometimes mood disorders. So ruxolitinib is a very convenient compound in those patients who are hydroxyurea resistant. And this is the CEMPO, Central European Myeloproliferative Organization, guidelines for treatment of polycythemia vera. In our setting, it's possible to use interferon as first line, and therefore we recommend interferon as first line, hydroxyurea in those patients where we cannot use hydroxyurea, and as second, let's say third line, JAK2 inhibitors, which are only licensed for those patients who show resistance to hydroxyurea or intolerance to hydroxyurea. Thank you for your attention.